to start the first presentation, which is very interesting, and a very interesting speaker, and all of North American physicians, they know Dr. Ram. So go ahead, Dr. Gad.
Thank you, Dr. Yasser. Thank you, Dr. Sameh. Today we will present Professor Rangasamy Ramanathan, Professor of Pediatrics, Division Chief of Neonatology, and Director of NICU at Los Angeles General Medical Center, Keck School of Medicine, University of Southern California. Professor Ramanathan directs one of the largest fellowship programs in neonatal perinatal medicine with around 18 fellows and more than 120 peer-reviewed articles published in many leading journals. We are honored to have you among us, dear Professor, in our conference, and much delighted to listen to your important lecture, Bundle Management of Bronchopulmonary Dysplasia, which is one of the very important topics and very stressful items in NICU management.
Thank you so much. Good evening. Can you hear me?
Yes.
Okay. So I'd like to thank the scientific committee for inviting me to participate and share my little knowledge. And actually, Professor Khalid Haque, who was in the endocrine, made my talk easier. So he focused a lot on golden minute and golden hour. And maybe now people are talking about golden week of management to reduce all the morbidities. And my talk today is going to be on bundle management of bronchopulmonary dysplasia. Bundle means basically take different approaches or different interventions that have been shown individually to make a difference in the outcome, and then bundle them together and see if we have an additive benefit, a synergistic effect. This has been very well done using quality improvement initiatives in the prevention of intraventricular hemorrhage. There are a number of studies have been published. So I'm going to today focus on bronchopulmonary dysplasia prevention. First thing is, what is BPD? We really don't have a consistent definition. It has changed. Almost 18 different definitions have been proposed, starting from 1967 through 2019. The most commonly used definition is the one NICHD in 2018 came up with. They removed the requirement for oxygen at 28 days prior to 36 post-menstrual age, added a requirement for chest X-ray confirmation of lung disease, and used a severity grading of 1 to 3, including incorporating the newer modes of non-invasive ventilation, as many of us are starting to use more and more non-invasive ventilation. Jensen looked at 18 different definitions, and the one that best predicts neurodevelopmental outcome as well as pulmonary outcome or death at 2 years of age came up with this definition: no BPD, there is no support. Grade 1, nasal cannula, less than or equal to 2 liters per minute. Grade 2 BPD, babies on more than 2 liters per minute or on NIPPV, nasal intermittent positive pressure ventilation. The baby is intubated. Grade 3, invasive mechanical ventilation. So this very simple definition, interestingly, they took out the days of oxygen, totally removed the days on oxygen throughout the NICU stay in the definitions. You will see more and more studies being published using the Jensen criteria rather than the classical 36 weeks post-menstrual age supplemental oxygen, which has been used for over 20 years since the original 2001 definition came up with from, again, a National Heart, Lung, Blood Institute workshop. So once we agree on a definition of EPD, then can we predict? This is a calculator that is often used when we counsel the families or when we teach. This is again from NICHD, Neonatal Research Network calculator for babies between 501 to 1249 grams. You select the gestational age, you select the gender, birth weight, ethnicity, postnatal day from day 1 to 28, and then ventilation type, high frequency or conventional or CPAP, or an oxyhood, or baby's not in any support. It can give you a prediction risk for BPD. There are number of other ways you can predict BPD. Lung ultrasound. Professor Yasser is an expert on that. So looking at this is a study from Spain in 2020, where they're looking at lung ultrasound scores on day 7 This is the 0 point, 1 point. This is B-line confluence. And then you can see classical changes that happen with PPD. These changes can be seen even on day of life 7. So they showed that on day of life 7, you get a lung ultrasound. In a small study, 42 babies, observational study, and they showed that you could predict the development of PPD. We looked at in a small study along with Professor Werder on using artificial intelligence, using spectral data of gastric aspirate done at birth, and then using clinical data in prediction of BPD or no BPD was considered accurate in samples with repeated cross-validation when exceeded 50%. Cross-validation is a method to evaluate how accurately the predictive model will perform in actual clinical practice. And we showed that 43% of the 61 infants developed BPD. Spectral data analysis of the gastric aspirate at the time of birth identified the most important wave numbers of classification, and for need for surfactant treatment, they used birth weight and gestational age as important predictive clinical data. So by combining these data, birth weight, gestational age, gastric aspirate, spectral data analysis, this algorithm using artificial intelligence for early diagnosis of BPD had a sensitivity of 88% with a specificity of 91%. So a simple point of care test to predict subsequent development of BPD so that you may intervene with early interventions in the bundle. So there are a number of predictive tools are available. There are also studies just looking at the chest X-ray. You do what is known as CRTA, chest radiographic thoracic area. You just draw free handwriting, a tracing, and then you look at it. CRTA had a significant positive correlation with the right shift of the oxygen dissociation curve and a negative correlation with the VQ. So they concluded in this study from the United Kingdom that CRTA can be used as a simple radiographic test to quantify the severity of BPD. So this is VQ mismatch. Here is the change in oxygenation and using the CRTA per kilo, and you can correlate with PaO2, and you can see the p-value significantly less than 0.001. So let's look at, okay, you know how to predict, you know what the risk is going to be within the first minutes after birth using spectral analysis of gastric aspirate or lung ultrasound or chest X-ray. That takes about a week. So you really have to start your intervention or bundle approach even at the time of birth. So here is a bundle approach that was published last year in 2021 from Rochester, New York. It's a level 4 NICU. They started this in December 2019. So some of the primary drivers are ventilation strategies, surfactant administration early in the delivery room or within 30 minutes, use of CPAP and or NIPPV, medications. They used vitamin A. They also used diuretics and other supplements, bronchodilators, and then optimizing the nutrition. These are the primary drivers. Secondary drivers are what type of ventilation strategy, high frequency ventilation, avoiding volume trauma or barotrauma. They allowed permissive hypercapnia. And then the changes that made, for example, the admission hurdle, all got together, the team members, and improve communication, and then the stabilization and transition criteria from the delivery room to the NICU. So these are some of the interventions they did. They optimized the CPAP in the delivery room, and then they had guidelines for the delivery room, and then specific criteria for CPAP failure before they intubate the babies. They also used education of the staff. Again, this is a team effort. Whenever you talk about a bundle, nursing, respiratory, neonatologists, trainees, everybody has to buy into this idea, otherwise it will fail. Here again, they had some gestation-specific interventions, 23 to 25 weeks. And they started on CPAP or PPV to establish the heart rate. Most important thing, heart rate saturation and avoiding temperature hypothermia, right? You heard from Professor Khalid's talk. So they get the heart rate over 100, then they intubated the babies, gave surfactant in the delivery room, and then transported the baby to the NICU intubated. And then initial ventilation, they had guidelines on how to wean, and then put the lines in, and then initiated the IVH prevention bundle. Routinely, they intubated the babies. Again, not everybody does this. We do not intubate routinely in babies between 23 and 26 weeks. So 26 to 27 weeks, they start on CPAP, give intubate and give surfactant, the ensure technique, and then consider extubation in the delivery room. If the baby is breathing spontaneously and the FiO2 is less than 30%, transported on nasal cannula, and then switch to bubble CPAP or wean the ventilation if the baby is still intubated. 28 to 29 weeks, they gave, if the baby got intubated as part of resuscitation or the clinical signs of RDS. And then they extubated the baby to bubble CPAP or continued the ventilation protocol. In 30 to 31 week gestation, CPAP if the baby needed, and then intubated if the baby needed as part of positive pressure ventilation. So pretty much between 28 to 31 weeks, they applied the same criteria. The only thing that different they did was routinely intubated babies less than 26 weeks. And the golden hour, again, their goals are 3. 1, give surfactant within 15 minutes of birth, and transport the baby to the NICU before 30 minutes of age. Put the lines, fluid management. You already have the babies coming. So what fluids are going to give and what labs you are going to get. Look at the blood gas and then antibiotics. All of them should be initiated within 1 hour of age. So, and then initial ventilator settings where they were using relatively low pressures, PIP of 16 or less, PEEP equal to 4, rate 30 to 40, and then they titrated the settings based on the chest rise and tidal volume. Early weaning, they after surfactant administration, get the blood gases as soon as the lines are placed, wean every hour and check the blood gases, extubate if the baby is breathing spontaneously and the peak inspiratory pressure is 14 or less, PEEP out less than 5, rate is less than 30, and the FiO2 is less than PCO2 is less than 50, and the FiO2 is less than 30. That's their criteria for extubating the babies to bubble CPAP. And FiO2 requirement, 30 to 40%. Again, the target saturation is more than 90% for 1 hour. PCO2, 55 to 65. So they used permissive hypercapnia, and the accepted pH 7.25 or greater. Hemodynamic instability, they followed the NRP guidelines. If the baby had multiple episodes of apnea, bradycardia, desaturation while on caffeine that required stimulation 12 hours, then they intubated the baby. So early surfactant, early intubation in babies that failed CPAP, and then early caffeine. So that was the major interventions they did. So what did they find? So this is gestational age less than 25 weeks, that is 23, 24, and 25 weeks. This is gestational age 26 to 27 weeks, the red bar. Green bar is gestational age 28 weeks or greater, and the purple one is all gestational age. You can see that they're able to decrease the BPD rate after initiating this quality improvement bundle in all groups. Obviously, in a younger gestational age, their BPD rate was 65%, and they were able to drop it to 50%. From 55, they were able to drop to 24%, nearly half in babies between 26 to 27 week gestation. And 28 week gestation, also they dropped from 20% to 12.3%. So they're able to decrease BPD rates, but more dramatic effects in 26 to 28 week gestation babies. In less than 25 weeks, they dropped it by about 15%, which is again, statistically significant improvement in their BPD rate. So this is the control chart. You can see upper control limit and lower control limit here. This is the average. This is what they started off in 2001 and then implemented the quality improvement bundle. And then in 2007 to 2011, you can see that they were able to reduce the BPD rate in the overall population from 33.5 to 16.5%. Most important changes in this quality improvement bundle, the golden hour approach. Second, gestational age-based delivery room protocol. For example, babies less than 26 weeks automatically got intubated. Early surfactant treatment within 15 to 30 minutes, and then timely extubation. They're clearly defined. And then they started NIPPV for babies less than 28 weeks. And overall, they showed a 51% reduction in BPD rates. So simple interventions, not many drug interventions, mainly respiratory, were able to reduce the risk of BPD. Again, intubation, invasive mechanical ventilation, and supplemental oxygen, two major factors in the developing lung and contributing to BPD. If you can avoid invasive mechanical ventilation the first 5 to 7 days, you're already out of the game. So think of BPD prevention as a golden week bundle. Then in California, one of my former fellow graduates, Maria Feviosis, published this paper in 2021 in JAMA Network. They also started a BPD prevention bundle between 501 to 1500 grams. Both in 2021 and both these studies, the reference rate was Vermont-Oxford Network BPD rate in babies less than 33 weeks. That was 24%. So they wanted to reduce it. So here they had 4 arms: ventilator management, pharmacological strategy, parent and family involvement for kangaroo care, and then other approaches. What did they do on the ventilation? Again, they routinely intubated a lot of these babies, put them on high-frequency ventilation, and babies less than 1 kilo or less than 28 weeks. And if they're in conventional ventilation, they used neurally adjusted NAVA, intubated invasive NAVA. And then in terms of pharmacological management, the antenatal corticosteroid use in this population was very high, or 98%. Early use of surfactant, started caffeine early, just like the Rochester study. Judicious use of postnatal steroids. They started inhaled steroids and bronchodilator therapy. Both of them have no evidence, but they started it on day 3. The baby is intubated. They gave inhaled steroids, budesonide, and bronchodilator treatment. They also gave vitamin A for the first 4 weeks. And interestingly, they also added erythropoietin until discharge. This is in an attempt to reduce the number of transfusions. We know blood transfusion increases the risk for both BPD and ROP, more so. So if we can maintain fetal hemoglobin, it's a huge advantage. And that's the reason they tried to use. And there are some individual studies that showed that erythropoietin administration has been shown to decrease BPD. That's where they took all these factors, interventions, and then put them together as a bundle. So mean birth weight was 1070 grams, mean gestational age, about 29 weeks. In terms of other approaches, they used fluid restriction to decrease the risk for BPD and PDA, infection control, and nutritional support, early TPN right after birth using a stock solution. Then less than 28 weeks or less than 1 kilo, which is 190 of the 484 babies, and then for babies over 28 weeks. So in the delivery room, they used early CPAP, intubated them. All babies got intubated, 23, 25 infants. And if they were over 8 weeks, by respiratory distress, they intubated the babies, or the baby required high FiO2 while on CPAP. They gave prophylactic surfactant. They used poractant alpha. They titrated the FiO2 to keep the saturation between 85 to 95. So I just highlighted what they did here. Intubate all babies between 23 and 25 weeks. Place them on high-frequency oscillator ventilator with a mean airway pressure of 9 to 10 hertz, 12, amplitude 25, and then kept this for a week at least. So they didn't extubate the baby. They did not try to aggressively wean and get the baby off the high-frequency ventilation in the first week. If the baby got extubated, they used invasive NAVA. They supported the baby quite a bit. The NAVA level of 6, Pmax 15 to 18 above the PIP. PEEP of 6, they had a backup rate of 40 and inspiratory term of 0.4 seconds. They actually give repeated surfactant dosing during week 1 and 2 if the FiO2 was more than 25. So their goal is to aggressively wean the FiO2 every day. That was their routine management protocol. Mean airway pressure was more than 10. Even if the FiO2 was 26 or 25%, they gave additional dose of surfactant. And interestingly, IVIG, intravenous immunoglobulin, weekly in babies less than 1250 grams until the baby regained 1250 grams. There are very, very few centers that use immunoglobulin, IVIG. Their thought process is that these babies are immunocompetent, that they don't get any protective antibodies from the mother, being born early, therefore they gave it. And one other unit that has very good outcomes, University of Iowa, Ed Bell's unit, they also used IVIG as part of their bundle. And they have very good results. So in babies between 28 to 31 weeks or 1 to 1.5 kilos, they used, again, started with CPAP, prophylactic surfactant if the baby got intubated. Again, the goals of saturation are the same, 80 to 85. In the NICU, they used NAVA as the primary mode of ventilation rather than high-frequency oscillator ventilation, like they used in babies less than 28 weeks. And then they used, if the babies are ready, extubated, they extubated them to non-invasive NAVA, NIV NAVA, neurally adjusted ventilator assist, and surfactant doses 2 and 3 as indicated. Extubate to NIV NAVA as soon as able and continue on until transition to high-flow nasal cannula only after 32 weeks post-menstrual age. Wean to RUMAT between 34 to 36 weeks and give a RUMAT challenge to make the diagnosis of physiological BPD at 36 weeks PMA if the baby is not on RUMAT yet. So the pharmacological approach is a busy slide, but basically I covered most of it. Early surfactant within 15 minutes of birth, additional doses based on FiO2 and radiological criteria in the first 1 to 2 weeks. Early caffeine started within hours to within a day. Erythropoietin, subcutaneous, starting in the second week of life until discharge from the NICU. Antibiotic stewardship. PDA, they used a conservative approach. Fluid restriction. Avoiding the use of diuretics, antacids, and anti-reflux medications. Again, most of us do not use that. And promoting optimal nutrition by starting a strict feeding protocol so you can rapidly advance and usage of breast milk. Neurodevelopmental assistance, early occupational therapy referral, pain management, minimizing the stress, containment, keeping the baby in fetal position, tucked in, avoidance of decrease of neurotropic medications. They rarely use sedation in their unit, and family-centered approach. Additional treatments for high-risk babies less than 28 weeks or less than 1,000 grams, vitamin A for 4 weeks, inhaled beta-2 agonist and inhaled steroids starting on day 2 to 3 until baby is off respiratory support. Again, there is no evidence for that, but they were using it. IV, dexamethasone for infants requiring mechanical ventilation at the end of second postnatal week. So they did not consider any steroids until the baby got to 2 weeks and the baby still requiring invasive mechanical ventilation. They also routinely screened for ureaplasma or mycoplasma in babies that were intubated and then started azithromycin. If the culture came back negative, they stopped it. The reason for that is their population, their geographical area, have a very high incidence of ureaplasma, mycoplasma colonization in the vaginal tract. That was the reason they did that. And there are some studies that have shown from Johns Hopkins that azithromycin in babies colonized mycoplasma, ureaplasma decrease the risk for BPD. So what did they find? So they were able to reduce BPD. This is where they started off at 31%. And they were able to drop it down to 2%. And there was a slight bump in 2017, but 2018 and 2019, they were able to maintain close to 0 or 1.6 to 2%. So this is the upper control limit, lower control limit, average here. This is their own data. Big drop. The initial implementation period and then final implementation period between 2015 to 2019. So basically, they showed that BPD in infants less than 33 weeks post-menstrual age, gestational age, decreased from 31% to 2%, a dramatic decrease in BPD. So what are we doing? This is the Canadian Pediatrics position statement in 2020. They haven't made any new recommendations that I'm aware of. Dexamethasone the first week after birth to prevent BPD is not recommended. It's a grade A. clinicians may consider prescribing a course of low-dose hydrocortisone, 1 milligram per kilo per day for 7 days, 0.5 milligram per kilo per day for 3 days, beginning in the first 24 to 40 years after birth, for 10 days to babies at highest risk for BPD. That is babies less than 28 weeks gestation or history of chorioamnionitis. There may be an increased risk for late onset sepsis associated with this practice. Hydrocortisone should not be combined with indomethacin prophylaxis because you increase the risk for spontaneous intestinal perforation. The routine use of inhaled corticosteroids to prevent BPD is not recommended. I just showed you the bundle from Kaiser, California, that they used inhaled steroids routinely. Additional recommendations, for evolving BPD is also not recommended. Dexamethasone is not used for prevention or early BPD or evolving BPD or exudative form of BPD in the first 7 to 10 days. For babies who remain ventilated after the first week birth with increasing FiO2 requirements and worsening lung disease, the benefits of dexamethasone appear to outweigh the potential adverse effects. So in those cases, they will use a low-dose dexamethasone, 0.15 milligram per kilo per day to 0.2 milligram per kilo per day, and then tapered over 7 to 10 day periods, almost like DOT protocol from Australia. Hydrocortisone to treat infants with evolving BPD beyond the first week of post-birth or infant with prolonged ventilator dependence is not recommended because hydrocortisone is not a very good anti-inflammatory drug. And BPD is an inflammatory lung disease. If you really want to make a difference, then you should use dexamethasone, but use it for a short period of time. Use it later, not in the first week or even first 10 days. Use of inhaled corticosteroids to treat BPD is not recommended. AAP came out to the postnatal steroid, corticosteroid use last year. So the original recommendation was in 2001. After 20 years, they came up with guidelines, recommendations. Routine use of postnatal corticosteroids cannot be recommended. Pretty much the same as what they did in 2001. Decision to use postnatal corticosteroids to prevent or treat chronic lung disease should be individualized and made together with the parents, and discussion should be documented in the patient chart. If a decision is made to administer postnatal corticosteroid, a low dose provided for a short predefined duration. That means, what do you want to do? I want to extubate the baby. And if you can't extubate the baby within 72 hours, you stop the corticosteroid. You don't want to keep continuing it. The infant does not show a clinical response within 72 hours. Continued treatment is not recommended with that medication. High-dose postnatal corticosteroids are not recommended to prevent or treat BPD. Indomethacin should not be used concurrently with mostly hydrocortisone. So let's look at what else can we do. This is two interesting studies by Professor A from Taiwan, and he was also in Chicago. So early intratracheal budesonide using surfactant as a vehicle to prevent BPD is a pilot trial, 116 babies, published in 2008. You can see it's 26 weeks, 800 to 900 grams. Antenatal steroid use was not great, 75%. Mortality, 16%. Control group, 32%. Even though it's half, it's not statistically significant, was a small number. However, death or BPD was statistically significant, 31% versus 60%. Survival without BPD was also huge. So he then went on and did a larger study in 3 NICUs, 2 from Taiwan, the other one is from Chicago Cook County Hospital, 265 babies. This study was published in American Journal of Respiratory and Critical Care Medicine. And surfactant with budesonide, surfactant only is the control, similar birth weight, about 800, 900 grams, similar gestation age to the previous study, 27 plus or minus 2 weeks. Baseline FiO2 was much higher, 60% in both groups. Depth, no difference. BPD, a significant decrease in BPD, 29% versus 50%. P-value less than 0.001. Death or BPD as a composite outcome was also lower. So they have 100 milligram per kilo of Survanta or surfactant plus budesonide 0.25 milligram per kilo. That's the standard dose. They use surfactant to distribute the budesonide steroid. Intratracheal steroid, not inhaled steroid. So where do we go from here? There is a phase 3 randomized controlled trial using poractant alpha budesonide called Preventing Lung Disease Using Surfactant plus Steroid plus trial. It's 1,060 babies. It's a multinational study in Australia, New Zealand, Singapore, and Canada. Primary outcome is free survival without BPD. They actually have completed the study. Trial has been completed. We just don't know the results yet. So let's wait for the results from this study, large trial. The other trial that we are waiting to hear is a mini DEX trial from United Kingdom. They used 50 micrograms of dexamethasone per kilo per day for 10 days and then alternated for 6 days. Again, they're looking at survival without BPD. So we don't have the results from this trial either. So take-home messages are early CPAP or NIPPV in the delivery room. We do not think that routinely intubating all babies is necessary. Oxygen air blender, you heard from Professor Khalid. Intubation for surfactant via LISA technique. Combining surfactant with budesonide may be a good option. There are 2 studies have been published, and hopefully PLUS trial will give us some more information. Early extubation if the baby is intubated to NIPPV. Start caffeine in babies less than 1250 grams, usually within the first hour or 2. Saturation between 85 to 90. Up to 33 weeks post-menstrual age and 90 to 94. Some people use 87 to 92. So midway, not too low, not too high. Nutrition support, start amino acid, 3 grams per kilo from day 1. Permissive hypercapnia, 45 to 65. Treat a hemodynamically significant PDA. Consider surfactant prior to extubation. And vitamin A, if the baby remains intubated at 3 days of age, that's what we do. Consider low-dose dexamethasone in intubated babies between 8 to up to 49 days. Really, some babies stay intubated and you gave steroids, dexamethasone didn't help. Studies have shown that even if you give it at up to 6 weeks after the baby, it has been shown to improve. If you're going to use it, there's a wide window of opportunity to use dexamethasone to treat. Use pressure or flow control system to deliver CPAP or NIPPV. I generally do not recommend high flow nasal cannula in babies less than 1 kilo until they're at least 32 or 33 weeks post-menstrual age. Clearly, NIPP is more effective than CPAP in reducing extubation failure. And again, early surfactant caffeine plus NIPP has been shown to decrease BPD in multiple systematic reviews. If you're using volume targeted ventilation, that has also been shown to decrease BPD compared to pressure ventilation. And we also want to wait for results from stem cell-based treatment, which Bernard Thibault from Canada, Ottawa, Canada, is doing it. First person to do that in babies. It'll be very interesting to see what he finds. Or IGF-1 plus IGF-1 binding protein 3. We are part of this trial. Hopefully we'll have some answers to that. Thank you so much for your attention.